It's been an amazing COMy, and great credit to the organisers for managing to get this all done remotely. What are the key issues? I think there are a number of key issues that we in the myeloma community are wrestling with. The first is our approach to smoldering multiple myeloma. We've seen a number of studies from Professor Gabriel and Professor Marie-V Mateus and Professor Lonial looking at intervening earlier in these patients with smoldering multiple myeloma. As with all things, we need a good definition of what is high-risk smoldering myeloma. And I think one of the discussions was around, do we treat these patients? Do we continue to enter them into clinical trials? And what is the best definition of high-risk patients? There's obviously the Mayo 2220 schema, which seems to be simple to use and does seem to mark out patients of greater risk. So I'd say that's one controversy. The second controversy is around high-risk disease. I think increasingly people are looking at patients with high-risk disease as a different group of patients from patients with standard risk disease. Once again, we run into problems with definitions. Clearly, we recognize standard definitions, patients with 17p deletion, 414, 1416, and 1420 abnormalities. But also we recognize that patients might have abnormalities of chromosome 1, and these might impact on prognosis. One of the things that I think we've been very keen on emphasizing in the UK through our Myeloma 11 trial is that we have to look not just at patients with one cytogenetic abnormality, but increasingly recognize that patients who carry two abnormalities, so-called double-hit myeloma, or patients that carry three abnormalities, are at much greater risk of their disease. And so high risk is really an evolving definition. And I think we have to recognize that we don't always know all high-risk patients. We still have a lot of work to do. Gene expression profiling can pick out other patients that are high risk. We recognize that patients with plasma cell leukemia at presentation or patients with extramedullary disease at presentation are also high-risk patients. Increasingly with better imaging, we also recognize that disease burden, previously measured perhaps with beta-2 microglobulin or LDH, disease burden as shown on PET-CT scan or whole-body MRI scanning can correlate with higher risk disease too. So ISS stage, standard FISH definitions of high-risk disease, but increasingly gene expression profiling, the recognition of double-hit and triple-hit disease are all important factors we have to take into account. And I think as a community, we have to work really hard at having a uniform definition of high risk so that we can compare diseases across clinical trials and really focus in on how we best help this group of patients who have a clear unmet need. I think finally, I would say that a group of patients that have high-risk disease that doesn't yet define definition are patients who either fail to respond to excellent remission induction therapy or relapse quickly after an autologous stem cell transplant. And these patients aren't always marked out by conventional genetics.